started the timer, and here is your question. Right. So if you have read and understood, kindly tell me, how would you position the patient to begin your examination?
Yeah, I'll ask the patient to stand. So first, after entering the room, I'll
Yes.
wash my hands, introduce
good.
myself to the
Yes.
patient. I'll confirm the name and age of the patient.
Good.
I'll take the permission from the patient to examine his shoulders, which will include the looking, feeling, and moving the shoulders. I'll
How
request
much
the patient
exposure
to.
would you ask for?
I'll ask the patient to take off the gown to expose the upper limb and the trunk.
Good. Then
And I'll also look for if he's using any arm sling or anything like that. I'll ask the patient to keep in a standing position.
Yes.
Then I'll start by looking both shoulders for any scars, swelling, deformity, or wasting.
Yes.
Starting from anteriorly, going on the side, then I'll ask the patient to turn back and also inspect from the back, both shoulders. After that, I'll ask if he has any pain at the moment. Before I'll start feeling the shoulders, I'll tell the patient that I'll be gentle. I'll feel for the temperature.
When would you ask
the
the patient? I'm sorry, I have to interrupt you. When would you ask the patient to sit down?
Actually, ma'am.
No. For palpation.
Most of the tests will be done in the standing position. So still, I'll ask the patient to stand.
Okay.
Yeah. I'll ask the patient if he has any pain, then feel for the temperature with the dorsum of my hand. I'll also feel the bilateral radial and brachial pulses. Then I'll feel the tenderness bilaterally over the, starting from the sternoclavicular joint, clavicle, acromioclavicular joint, coracoid process, over the head of the humerus, over the greater tuberosity, and also behind the spine of scapula as well as acromion. Then I'll start looking for the active movement. I'll ask the patient to imitate me. For flexion, raising the arms forwards and upwards to full. For extension, keeping the arm straight and moving it behind. For abduction, leaving the arm away from the sides as high as possible, as well as for adduction, I'll ask the patient to bring the arm across the trunk on the opposite side.
You're asking the patient to do active movement.
Yeah,
abduction, and patient
imitate,
yes.
and I'll ask the patient to do the same.
Yes.
Yeah.
Patient is feeling pain after you ask the patient to abduct over between 60 to 120 degrees. So what would you do next? Patient is having pain.
If patient has pain, then this will be the positive for painful arc. And I'll ask the patient that.
I'm not asking what this is for. My question was, what would you do next?
I'll first say sorry, and then I'll ask if he needs any painkillers immediately or not. And I'll say that I'll be gentle for any further movement. Okay. If he feels too much pain, then I'll not do any further examination.
Okay. Yes.
And
then
yes.
Yes. How would you conclude your examination? Would that be the end of your examination, or would you go ahead and carry out other parts of the examination?
Okay, then after active movement, I'll also check the passive movement if patient allows me. for bilateral
Okay.
shoulders, and also
Okay.
feel the crepitus at the same time in the joint.
Good.
After that, I'll ask the patient for empty can test to assess the supraspinatus. I'll ask the patient to straight the arm, pointing the thumb downward. Then I'll push it downwards and ask him to resist. And then I'll already see if there is painful arc present or not. And then I'll also ask the patient to do the external rotation. I'll give the resistance against the external rotation for seeing the infraspinatus status. After that,
Patient is having pain. Would you go for neurological examination?
If patient is having pain for any movement, I'll
Yes.
Go for the sensory examination over the army badge area. I will not do any further movement or
Yes.
further examination over there. I only do the sensory examination. And
For which
also,
nerve?
it will be over the army badge area, which
Yes.
is supplied by the axillary nerve.
Good, good.
And
Okay.
if patient cannot even do the this testing, pushing the against the wall with outstretched hand, then also I'll leave it. I'll do not press the patient to do anything else. I'll then thank the patient and help him putting on the gown. I'll assure him that after discussing the case with the consultant, and I'll let him know about the further course of action. I'll ask him if he needs any further help. Then I'll wash my hand.
Okay, you still have 30 seconds. So can you present your case now, please?
So to complete my examination, I'll also do the cervical exam, spine examination, elbow examination, and also complete neurovascular examination of both upper limbs.
Very good.
So today I've examined this gentleman who presented with shoulder pain. There was no swelling, scar, deformity, or wasting. As while doing the movement, patient has severe pain. So I did not do any further test. I should have done the empty can test and movement, but due to pain, I did not do. And
okay. So what is your provisional diagnosis?
So my provisional diagnosis is rotator cuff tear. I also consider it for a subacromial impingement or supraspinatus tendinitis or adhesive capsulitis.
How do you prefer to manage this patient?
First of all, I'll advise the patient for an X-ray shoulder joint and followed by the MRI of the shoulder joint. I'll also advise the full blood count, TTI electrolytes, and coagulation profile. And on the basis of the X-ray and MRI examination, I'll discuss the case with the consultant, and then I'll offer the patient to start with the conservative treatment, which will include the lifestyle modification, exercise, and physiotherapy. I'll also offer the analgesics, which can be topical or oral. And as per MRI report, if there is any rotator cuff tear or impingement, then I'll advise the patient to go for arthroscopic treatment with arthroscopic repair of rotator cuff tear or acromioplasty for impingement.
Very good. Okay. Right. What would you advise patient? What more would you do if patient is a professional athlete and patient cannot continue with his profession? So what more would you advise?
I advise the patient to avoid this sports activity because it will cause the further damage to the rotator cuff, and
how long patient cannot?
At least for 9 months.
Okay, good, very good, very good. Okay, good. Simon, and thank you so much. It was excellent. I mean, it was really mind-blowing. It was excellent. You answered every single question. If it was your exam today, you would have passed easily. So anyone else want to give any feedback?
Hello, Dr. Suman.
Yes, please.
One. So I cannot say anything regarding this station, definitely. But the thing is, bro, you firstly told that it's rotator cuff tear. So should we go for rotator cuff tear first, or just painful arc syndrome due to
actually, if it is too much pain, I don't know, as actually it should be first impingement syndrome, then adhesive capsulitis. Rotator cuff tear should be last, but I don't know, man said that too much tear and he has a sports person. So the first diagnosis would be the rotator cuff tear, which most probably is acute.
Actually, when Simula said that whenever you are just doing the examination, the abduction one, I'm just told that between 60 to 120 degree there is pain. So that's why I just thought maybe first of all, severe one.
Actually, the 60 to 1, I know you are right. But 60 to 100 degree is an indication to impingement syndrome, or but it is also a case in supraspinatus tendinitis or supraspinatus tear.
Okay. I see.
Actually, it is for two things: either supraspinatus or impingement. In impingement, also it is the impingement of supraspinatus tendon against the acromion. Yes.
So subacromial shaving we do actually arthroscopy.
Acromioplasty. Yes.
Acromioplasty. Yes. Yeah. Great, brother. Just keep doing it. That's it.
No, you.
Here is your question. Right. So if you have read and understood, kindly tell me, considering the critical care scenario, how would you manage this patient?
Okay, I'll manage the patient starting with the ABC protocol.
Yes.
So as is, as the patient's, as the patient's GCS is now 8, so he is a candidate for intubation.
Okay, but how would you go about? How would be the position of the patient? Please tell me everything.
Okay, the patient.
What ABC
should be
stands for? Yes.
Okay, so I'll start with the airway.
Yes.
I'll check if there's something in his mouth that needs to be removed, if it's causing any obstruction, if there's a presence of stridor. So once I'm done with that, I'll look for his breathing pattern, and then I'll move towards his circulation. He has to be given two wide bore IV cannulation in his arms.
Yes. And position will be?
He should be in supine position with his cervical spine immobilized. Okay. So he most likely has raised ICP, so that needs to be managed. So firstly, we have to improve the venous drainage from the brain. We'll elevate the head of the bed to at least 30 degrees.
Yes.
The neck should be aligned in neutral position. It should not be towards any one side. And if the patient, once the patient has been intubated, we should make sure that the endotracheal tube is not compressing any of the neck veins.
Okay.
Also, the cervical spine needs to be stabilized.
A patient has GCS 15 when patient arrived, and now patient has GCS of 8. Can you please tell me how do you calculate class performance scale?
Okay. There are 3 components to this scale.
Yes.
The first is eye-opening, second is verbal response, and the third is motor response.
Okay.
So the minimum score that one can get in here is 3, and the maximum is 15.
Okay.
So for
Considering
in
this patient
case-
has 8 glaucoma scale, so where does this patient lie? At what grade or at what level?
that means
Is
he has a
any-
low
yes.
GCS and he
Is
should be
any-
intubated.
yes. Okay. Can you tell me the pathophysiology of increased intracranial pressure, please? That Monro-Kelly hypothesis. What is it?
Okay. The Monro-Kelly hypothesis suggests that the skull is, and it has 3 components, the brain and the CSF. And increase in volume of any one of the component would result in a compensatory decrease in order to prevent.
Is it my network or is it yours? You disappeared or I disappeared? Can't hear you.
That would result in a marked increase in the ICP. And this is called decompensation. And that is what.
I'm sorry, I got disconnected.
Oh, okay.
Okay, please tell me what do you understand by the term lucid interval?
Okay, lucid interval, it is at the time period in which there's a temporary improvement in the patient's condition after any traumatic brain injury. And after this is followed by a rapid decline in the conscious level.
Okay.
And this occurs, okay.
Yes, please. What should be the normal value of intracranial pressure?
Okay, the normal value of intracranial pressure is about, the range is from 7 to 15 millimeters of mercury in supine
Very
position.
good. Okay, good. Okay, can you please tell me, would you not go for the lumbar puncture for this patient?
I will not go for lumbar
Why?
puncture
Yes,
because he clearly has signs of increased intracranial pressure.
yes. What can happen?
So that would cause herniation of the cerebral tonsils.
And coning. Yes. Okay. What are the components of Cushing triad?
The triad consists of bradycardia, hypertension, increased systolic blood pressure,
And dyspnea.
and okay.
Okay. Yes. What is Cushing reflex? How would you differentiate it from Cushing triad?
Cushing reflex. I don't know.
Okay. Can you please name some ways with which you can measure intracranial pressure?
Yes, we can measure it with an EVD, extraventricular drain.
How would you classify them? Invasive and non-invasive.
Invasive and
tell me.
non-invasive.
Yes. Now tell me.
Okay. So in invasive, we have EVD, intraparenchymal probe.
Yes.
There is extradural probe, a subarachnoid probe, and for non-invasive, we have transcranial Doppler and tympanic membrane displacement method.
Yes. Okay.
Also, lumbar CSF, that would be an invasive lumbar CSF pressure.
If you are asked to do the CT scan of this patient, how would that look like? Or can you help me read this? What are you looking at?
Okay. Okay, this shows a biconvex hyperdense lesion. And there's a midline shift and compression of the lateral ventricles.
You said this patient should be intubated. Can you name few benefits of intubation?
Benefits of intubation, as the patient.
Yes.
So this would be helpful in that.
Yes. In what ways? How would you, yes, how would you prepare the ventilator? How would it be like, if you can tell me? In this situation, patient is placed on, patient is intubated. How would be the settings of ventilator?
CMV mode, the patient needs to be paralyzed. And I'm not sure about this one.
Okay. Can you please tell me what are the advantages of trachea-tube?
Sorry, ma'am, can you repeat that?
Tracheal tube, yes.
Tracheostomy?
I didn't say tracheostomy.
Okay. An ETT, an endotracheal tube.
Yes,
It
what are
prevents
the,
it
yes.
prevents the tongue from falling back,
and
and it's an artificial way of ventilation.
this you can read on in all those traditional notes. Yes, it's given there.
All right, ma'am.
And why
Okay.
you would choose to intubate? You should know at least 4 different reasons.
Okay, ma'am.
Yes.
All right.
All right. There could have been many more questions, but time went. But after there is the question. Right. So if you have read and understood, kindly begin your station.
Hi, my name is Dr. Bilal. I'm one of the doctor here on duty today.
Okay.
I've been told that you want to talk about your son's surgery with me.
Yeah, doctor, I don't know actually what does happen to my son actually. I was really was not at home. I just thought I just heard that he's so much he got injured, and why the operation is going on, doctor? Please tell me. I don't know anything.
I'm really sorry about this, what happened. Can I please confirm your name and how you would like me to address you?
I'm Samantha, and you can call me Miss Samantha. No problem, doctor.
All right. So, Miss Samantha, your child fell off from a swing in the school today. And when he was brought in the hospital, his father was accompanied him, and he has given a permission for the surgery. That is why it was very important for us to take the child to theater on emergency basis to repair the defect.
Oh, okay. So how did he fall? Do you know, doctor? Please, can you tell me?
So we have been told that he has fallen from swing in the school, and after that he got unconscious and he had an abrasion on his abdomen.
Oh, okay. So after coming here, what did you do for my son? You just directly took him to the operation theater. What did you do? Any test, anything, doctor?
So on his arrival, a scan was done to see any injuries inside his tummy, and we found that there was a laceration injury to his spleen, which needs to be repaired on urgent basis. Since this is a very serious injury, we have taken the patient to the theater on urgent basis.
Oh, I see. So what do you mean by spleen, doctor? What is its importance? Can you please tell me more?
So spleen is one of the major important organ in our tummy, and it plays a vital role in body's defense mechanism.
Oh my God. Is it so that much serious, doctor?
Unfortunately, I'm sorry, it is a serious injury, but I can assure you that your child is in very good hands, and we will try our best to save his life.
Oh, okay. So what did his father actually told you? I know that he's a very drunk person, And what did he actually told you? Like, what was he doing during that time?
So he told us that the child was in his school while this injury was happened today.
Okay.
And he was playing on a swing, and from the swing he had a fall and he injured himself.
Oh, okay. So, doctor, I just want to tell you another thing that as he's a drunk person, I have already told you. I just want to protect my son. So, could you please help me in that regard, prevent future these type of events in the future?
Yes, in all these types of injury, we always involve the social care and child consultants to make sure that the patient is safe. We will arrange a home visit as well to see if everything is okay and he has got a proper environment, right environment for him at the home.
Oh, okay. So after this operation, will my son actually need any type of medication, any type of abnormality he will face, something like that? Can you please tell me more, doctor?
So if the spleen is removed during the surgery, he will need some long-term antibiotics to protect him from the infection. As I mentioned before, the spleen plays a very important role in body's defense mechanism. So once the spleen is removed, there's a high chances of certain infections. And to protect the child, we need to give him long-term antibiotics. Sometimes it could be lifelong as well.
Oh, okay, doctor. I'm really feeling so bad, doctor, for my son. I just want to see him. Can you please tell me how long this operation is going to last? Can you please take a look and tell me?
I'm really sorry about what you are going through at this time. Unfortunately, we cannot predict about the exact time duration of the surgery. As soon as the surgery is done and he's out of the anesthesia, I will make sure that you get to see him as quickly as possible.
Oh, okay. So when can I take him home actually after the operation? How many days he'll need to stay in hospital?
It will take a couple of days till he gets normal and stable. We do serial examinations. We will check him on a daily basis. As soon as he's stable and he's able to feed himself, we will discharge him with a follow-up plan and you can take him home.
Oh, okay. Thank you so much, doctor, for telling me these things. Thank you so much. I really appreciate it.
You're welcome, Samantha. If there's anything else you would like me to explain, please call me anytime. You can ask the ward nurses to call me. I'll be more than happy to answer any question if you may have.
Ask if the patient,
Oh, okay, doctor.
if the
That's so
consultant
kind of
is
you.
expert. If consultant is expert
Sorry,
in
ma'am?
this surgery, ask if consultant is expert in this surgery.
Oh, okay. So, doctor, can you please tell me one more thing? How frequent your surgeon actually do this type of operation, and how is the success rate, something like that? Is he an expert in doing this?
Child trauma are very common and our surgeons are very competent. And as I assured you before, he's in good hands. If there's anything else, I will talk to my consultant and I will let you know about the prognosis of the surgery.
And what are the
Okay, doctor,
complications that can occur?
Oh, any complications that can occur after the surgery, doctor?
Some complications are common, but they don't occur very frequently. For example, infection, scarring at the site of surgery, sepsis, wound adhesions, or bleeding after the surgery. But in case if they occur, we will control them very quickly and efficiently.
Oh, okay, doctor. That's so nice of you. Thank you so much.
You're welcome.
Thank you. Okay.
Actually, you did very
You can
good.
summarize.
Yes, you still
Dr.
have 1 minute. Yes.
Yeah, you can summarize these things.
So I discussed a case of a child with the patient's mother. I explained about the type
No,
of
you're
injury.
you're
No.
summing it up to for the mother, not for the consultant. So
yeah,
you just say what we have discussed so far. Yes.
Okay, so just to sum up what we have discussed so far, your child was brought in with a laceration on his abdomen on upper left side. We were suspecting some intra-abdominal injury in his tummy, so we did a scan which suggested a laceration to his organ called spleen. And to repair that organ, we have taken him to theater on urgent basis. Currently, the surgery is going on. As soon as surgery is done, I will try my best to arrange to get you to him. And after he gets stable after the surgery, he will get a vaccination for certain diseases which are very common in children who get a surgery of spleen, and he may take long-term antibiotics as well. In addition to those things, I will make a referral for a child care to visit your home.
Very good.
I get it. Thank you.
Thank you.
Very good. Yes, that was within given time, and you covered and you communicated really well. Patient's mother was satisfied.
Yeah,
and yeah.
it is good.
Any feedback, Dr. Abhishek, you would want to give him directly?
So it's like, okay, it's really good, Dr. Bilal. You did it in a very nice way.
Yes,
And
professional.
you asked my name, and you could ask about like the relationship with this. If the name of the boy is given already, something like that.
Yeah.
And if my name is already given, you can just confirm it, or you can simply ask like, are you there, like excess mom, something like that. Other than at the last, whenever I asked you how long it could need, so giving assurance like within a couple of days, it's some kind of, I think, to me actually, I think it's some kind of promises. And after that, even if complication happen, if the boy is needed to be hospitalized more, then some kind of mishap can happen, like why it is taking more time. So never, like in this type of communication skills, never give any assurance, any promises.
Never make
You
any
can just say,
promises out
yeah.
of the way. Like never go out of the
So
way.
just
to make
say that
promises.
we'll try a good recovery for your child. We'll do repeated examination. Whenever we'll find that your son is good enough to go home, then we can discharge him, something like that. That would create more good appearance in the exam, I think. Other than this, everything went well, definitely.
Yes. Anyone else want to give feedback? Yes. So timer has started, and here is your question. Right. If you have read and understood, and considering its surgical pathology station, can you tell me what is the pathogenesis of this condition? In which there is yes, adenocarcinoma with melanosis coli. What do you understand by that?
Melanosis coli. Actually, melanosis coli is a benign condition in which there is pigmentation of colonic wall, and usually detected during the colonoscopy.
Okay. What is the most common type of colon carcinoma?
The most common type of colon carcinoma is adenocarcinoma.
Okay. So this patient has adenocarcinoma. So what do you understand on histopathology report? If patient has melanosis coli, how would you understand what is the lesion? Report states that lesion to muscular flares. What do you understand by this?
Actually, the report says that the adenocarcinoma and the lesion involves the muscular layer. It means that it is the in the staging of Duke staging of B, or better I'll say B, Duke staging B, and
How are you
TNM staging.
classifying?
It is
How are you classifying
Yeah,
these
we can
tumors?
classify the colorectal cancer as according to Duke staging or TNM staging. In
Okay.
Duke staging, it can be divided into stage A, B, C, and D. In A
Yes.
further can be divided into B further can be divided into B1 and B2 and C into C1 and C2. In A, the tumor reaches up to submucosa. In B1, it reaches up to muscularis propria, and B2 it reaches to serosa. While C1, when there is lymph node involvement up to 3, and C2 when 4 or more lymph nodes are involved, and D is when there is distant metastasis. While in TNM staging, tumor can be divided into the T1, T2, T3, and T4. In T1, it involves the mucosa and submucosa, while T2 involves the muscularis propria. T3, in T3, it involves the pericolic fat, and T4, it breaches the serosa and also can involve the local organs. And in N stage, if there is up to 3 nodes, involvement is N1, and more than 3, I mean 4 or more is N2. And if there is metastasis, then it is M1.
Can you please tell me what are the risk factors causing carcinoma, colon carcinoma?
Risk factors for colon carcinoma are the high fatty diet, smoking, and low fibers diet, and there is inflammation like inflammatory bowel disease, and there are and that's it, ma'am. I go to the next.
Okay, how would you define the term adenoma, and how would you differentiate it from carcinoma? The terminology.
Adenoma is a benign epithelial neoplasm which either arise from the glandular cells or it has a glandular pattern, and it is benign, while adenocarcinoma is a malignant condition which arises from the adenoma itself or from the other cellular tissue which has glandular pattern later on.
Other
But
than
it is a
adenocarcinoma, what are the other carcinomas of colon that you know of?
Other than adenocarcinoma, there may be, I think there is a squamous cell carcinoma.
Are all
And,
carcinomas of the colon metastatic are malignant? I'm just forgetting the word. Yes, are all the carcinomas of colon malignant in nature?
Actually, all the tumors of the colon are not malignant.
Yes.
There may be benign as well as
Yes.
malignant also.
Yes. So can you name?
Like hematoma, and there are carcinoid tumor, hematoma, and
how should a patient, suppose this patient, be called for follow-up? How frequently patient should be followed up, and what should be included in the follow-up of this patient?
Follow-up. Actually, ma'am,
Yes.
if we diagnose the case of colorectal carcinoma, we'll manage this patient and do the total colectomy, and then after that follow up. Sorry,
Yes.
ma'am.
Okay, if a patient has a history of colon carcinoma, how would if patient has strong history of colon carcinoma, how would the follow-up of that patient differ from the other patient who does not have any family history?
If the patient has family history of colon carcinoma, then
yes,
the patient as well as the children should be followed, and it should be screened by colonoscopic by up to the age of 12 years.
Okay.
By the age of 12 years.
Okay, maybe you'll start early if patient has strong Okay, can you tell me if there are any advice that you can give to this patient to avoid or to prevent colon carcinoma to occur? Or to
Yeah,
take
I'll
place?
advise the patient. I'll advise the patient not to take high fiber diet, avoid
Okay,
smoking,
good.
and a low fat diet, and
Okay.
mm, yes.
What are the genes which are associated with colon carcinoma?
Actually, there are mainly 3 types of genes.
Yes.
That is the KRAS
Yes.
genes, then KRAS
And?
proto-oncogenes. There is a AFP tumor suppression gene, KRAS proto-oncogenes, and P53 tumor suppressor gene.
Yes. What is more important about the KRAS gene? Is there any important?
Actually, KRAS, it is the proto-oncogenes, which if convert, its main function is it uses the GTP signaling pathway when it produces the KRAS protein, which binds to the GTPs, and then it signals the nucleus to get the cell proliferation. And when this converts into the oncogene, then this gives the continuous stimulation to the cell to proliferate, and then it can cause cancer.
Good. Thank you. Yes, it was good. Little brush up, it's good. If you'll do it, it will be perfect. Anyone else want to answer? And you already know which questions you need to.
Yes, ma'am. Actually, I read today this from the single note, and
Here is your question. Right. So if you have read and understood, considering it critical care scenario, tell me, how are you going to manage this patient? Please.
Okay. So this patient should be given calcium gluconate intravenous, 10 ml of 10% calcium gluconate, which is followed by 40 ml of normal saline infusion over a period of 4 to 8 hours. And also a cardiac monitor should be attached to the patient.
Okay. So what would you do first?
After administering a calcium gluconate?
Yes. Can you tell me why this patient might have this condition? What is the provisional diagnosis that you're thinking?
Okay.
Why this patient?
The patient is suffering from
Yes.
The patient is having hypocalcemia, most likely due to removal of the parathyroid glands during total thyroidectomy.
Yes, patient is post-op. Yes, and then is this level
so
of
that is
1.7
one reason,
millimole?
or
Yes, this level of 1.7 millimole per liter is what does it signify? What does it tell you? What should be the normal level?
Hypocalcemia.
What should be the normal level?
It should be greater than 2.6.
Yes. Okay, good. Okay, can you tell me how this calcium is transported in the body?
Okay, it's transported mainly in three forms.
Okay.
50% of calcium is in ionized form, 45% is attached to plasma protein, and the remainder 5% is attached with anions such as citrate or lactate.
Okay. So what is the most active form in which it is present?
The unbound form,
Why do we need calcium?
or in the ionized form.
Why do we need calcium?
It has a number of functions within the body. It is important for contraction of the muscles. It acts as a neurotransmitter. It's required for activation of the coagulation system, for mineralization of bones, and also for glycogen metabolism.
Okay. Can you please tell me? How this calcium is absorbed in the body?
How it's absorbed?
Yes. What happens in the body? Like
Okay.
which organs are involved in? Yes, full circle. If you can tell me.
Okay. All right. There are three hormones which regulates the calcium homeostasis.
Yes.
First is parathyroid hormone.
Yes.
It acts on the bones as well as the kidneys. In the bones, it causes an increase in osteocytic and osteoclastic activity, which causes bone resorption and thereby increasing the calcium levels within the plasma.
Okay.
And then in the kidneys, it causes it reduces the renal calcium loss and increases the phosphate excretion. And it also stimulates 1-alpha hydroxylase within the kidney, causing formation of calcitriol, which is the activated form of vitamin D3. And then that causes increased calcium reabsorption.
Okay.
So that's the action of
This
parathyroid
vitamin
hormone.
D acts,
Then we have
yes. On which
Yes,
organs? How does it? Yes. On which organs?
Okay, so it
vitamin
acts
D
on bones, on the kidneys, and also on the gastrointestinal system. So in the gastrointestinal system, it causes increased absorption of both calcium and phosphate.
Yes.
In the kidneys,
bones?
it causes reabsorption of both calcium phosphate, and then in the bones, it stimulates osteoblastic proliferation, and it causes an increase in serum calcium, and it also causes calcification of the bone matrix. Then lastly, there's calcitonin. It acts
yes.
on the kidneys
Yes.
and the bones. In the kidneys, it causes excretion of calcium and phosphate, and in the bones, it inhibits bone reabsorption by
yes.
inhibiting the osteoclasts.
Can you please tell me the mechanism why hypocalcemia causes shortness of breath?
Okay.
Yes.
Shortness of breath because of involvement of laryngeal muscle, as it will go into laryngeospasm.
Okay. Does that lead to obstruction of the upper airway? Okay, can you tell me what other?
Yes.
Sorry. Can you please tell me what other signs of hypocalcemia do you know of, which has not been mentioned here?
Okay. It could result in peripheral or circumoral paresthesias, abdominal cramps, spasms. Then we have two signs,
Yes.
Schwastic sign and Trousseau sign.
Yes.
Okay, in Schwastic sign, if we tap the facial nerve anterior to the tracheus, that results in twitching of the facial muscles. And Trousseau sign occurs when blood pressure, cough-induced this arm ischemia, and that causes spasm of the hand.
Okay. Why there is numbness and this tingling sensations and carpopedal spasm?
Because of low levels of calcium.
Okay. Why there is abdominal pain because of hypocalcemia? what happens?
I don't know the exact mechanism.
Okay. Can you please tell me what hormones? You've already told me this one, the hormones which are okay. How it is metabolized, vitamin D3?
Okay. The cholesterol which is present in our bodies, it gets acted upon by UV rays. It turns into
Skin, yes, sun, yes.
cholecalciferol.
Yes.
Yes. Then within the liver, it gets converted to 25 hydroxycholecalciferol. Then within the kidneys, 1-alpha hydroxylase acts on this and causes formation of 125 dihydroxycholecalciferol, which is vitamin D3 or calcitriol.
You said patient should be monitored as well. If you're doing ECG, what ECG changes are you looking for, if any?
I'm not sure. There would be a QT prolongation.
Anything else?
And that's all I can think of.
Okay, did you tell me how much dose? I think you did tell me how much dose you will give. Bella is gone, but I want you to tell me. Did you tell me?
Yes, I'm 10 ml of 10% calcium gluconate.
Okay. Is there a way you can classify hypocalcemia on the basis of the result?
Primary and
mild, moderate,
secondary,
and severe.
Oh, okay.
Okay, that can also be
all
because
right,
this
okay.
is post-op. So yes, I wanted you to tell me the severity of the hypocalcemia.
Okay.
Okay, why should you be worried when a patient is having tetany?
Because the laryngeal muscle can also get involved, and that can cause a laryngeospasm,
Good.
resulting in obstruction of the airway.
Good. Okay, very good. Okay, yes, a little bit is left. Otherwise, yeah, you did well. Anyone else want to give feedback? Do I have anything else? No.